I'm Jean Jose from the University of Miami. We're going to be discussing basic MRI anatomy of the hip. This is intended as a tutorial for medical students and radiology residents. We'll begin by discussing the regional muscles. We'll talk about the hip adductors, the hip abductors, the external rotators, the extensors, and the flexors. So the hip adductors include the pectineus, the adductor brevis, the adductor longus, the adductor magnus, and the gracilis. The pectineus attaches to the superior pubic ramus and will insert in the medial aspect of the proximal femoral diaphysis, and it will be the most anterior and superior lateral of the hip adductors. The pectineus is a medial rotator as well as a hip adductor and a hip flexor. As we travel more inferiorly and medially, posterior to the pectineus, we'll see the adductor brevis, then the adductor longus. The adductor longus will attach to the pubic tubercle along the anterior margin of the pubic body, and it will be continuous with the rectus abdominis to form the rectus abdominis adductor longus aponeurosis. And this is an area of injury commonly known as athletic pubalgia or sportsman's hernia. Now, deep to the adductor longus and more medially, we will find the adductor magnus that will attach to the medial aspect of the ischiotuberosity, and then it will travel distally to insert along the medial aspect of the femoral diaphysis at the linea aspera, as well as distally into the adductor tubercle along the medial aspect of the distal femur. Medially, we will find the gracilis, which will insert distally along the anteromedial aspect of the proximal tibia, together with the semitendinosus and the sartorius to form the pes anserinus, also known as goose's foot. So here we see the adductor longus attachment to that anterior margin of the pubic body. We also start seeing portions of the adductor brevis and the pectineus. Now, between the superior and inferior pubic rami, we will see the obturator foramen, and around the obturator foramen, we will see two separate muscles. The one that is deep to the obturator foramen is the obturator internus. The one that's superficial is the obturator externus. Gracilis, portions of the adductor magnus, adductor longus, and adductor brevis. Here we see that adductor magnus. So the rectus abdominis attaches with the adductor longus along the anterior margin of the pubic body, and this forms the rectus abdominis adductor longus aponeurosis. This attachment is a few millimeters medial to the superficial ring of the inguinal canal. Here we see the inguinal ligament or Poupart's ligament traveling from the anterior superior iliac spine into the pubic tubercle. We also see portions of the sartorius that also attaches to the anterior superior iliac spine. Pectineus, adductor brevis. So here's a close-up image showing the rectus abdominis. Here's that pubic body, and on blue, this is the adductor longus tendon, and we see portions anteriorly of the pectineus. The adductor brevis will be posterior to the pectineus. Here on the sagittal MR image, we see the rectus abdominis inserting. We see the adductor longus. Deep to that, we have the adductor brevis. We get to the area of the obturator foramen. We see the obturator externus and obturator internus. Here we see the adductor longus attaching anteriorly to the pubic body, the pectineus. Deeper, we start seeing some fibers of the adductor brevis there. That's portions of the pectineus there. And then, as we extend posteriorly, we see the obturator externus, the obturator internus, the obturator foramen. Posteriorly, we will see portions of the adductor magnus. Here we see the gracilis. As we travel posteriorly towards the ischiotuberosity, medially we'll see the adductor magnus. More laterally, we'll see the semimembranosus origin, and then the conjoint origin of the biceps femoris and semitendinous. On axial images, we'll see the pectineus anteriorly, obturator foramen, adductor brevis, obturator foramen, obturator externus, obturator internus, adductor longus attaching towards the rectus abdominis, together forming the rectus abdominis adductor longus aponeurosis. In terms of the hip abductors, those include the gluteus medius, which is also an extensor, the gluteus minimus, which is also an extensor, the tensor fasciolata, which travels within the iliotibial band, and the sartorius. Now the hip adductors, the gluteus medius and minimus, will insert into the greater trochanter. These are large field of view coronal T1 weighted images through the pelvis, and we see these muscles traveling from proximal to distal in a lateral to medial, and these are the sartorius muscles. The sartorius will originate at the anterior superior iliac spine together with the iliotibial band, and then will travel from lateral to medial to insert onto the medial aspect of the proximal tibia in the region of the pes anserine. Now, as we travel from anterior to posterior, the next muscle we see laterally is the tensor fascia lata. This is the iliotibial band, again also attaching to that anterior superior iliac spine as well as superior lateral margin of the iliac crest. This is the gluteus maximus. We also see the gluteus medius and minimus. When we look at the greater trochanter, we'll see that there are four main facets, and that is going to play a significant role in identifying the tendon insertions as well as the location of the trochanteric bursae. So if we look at this diagram, anteriorly we'll have the anterior facet, and that will be the site of attachment of the gluteus minimus tendon. Deep to the gluteus minimus tendon, we will see the subgluteus minimus bursa. Along the lateral and superior posterior facet, we'll see the attachment of the gluteus medius tendon, and deep to that we will see the subgluteus medius bursa. Along the posterior facet, we will see the area of the true greater trochanteric bursa that extends from the posterior facet and into the lateral facet deep to the iliotibial band. So on the sagittal image, anteriorly we see the anterior facet, which will be the site of attachment of the gluteus minimus tendon. We start seeing portions of that lateral facet, which will be one of the site of attachments of the gluteus medius tendon. And then as we extend more medially, we see the superior posterior facet, which is another site of attachment of the gluteus medius tendon. As we extend from posterior to anterior, we see that superior posterior facet, and we see that main attachment to the gluteus medius tendon. As we extend more anteriorly, we see that lateral facet, and we see that other attachment to the gluteus medius tendon. As we continue further still anteriorly, we see the gluteus minimus tendon anteriorly attaching into that anterior facet here. Now, at the level of the lateral facet, we also see portions of the iliotibial band, and deep to the iliotibial band and overlying that posterior facet and the lateral facet will be the site of the true greater trochanteric bursa, also known as just the trochanteric bursa. On this coronal image, we see the gluteus minimus muscle, gluteus medius muscle, and gluteus maximus muscle. On our axial images, the more anterior muscle will be the gluteus minimus, followed by the gluteus medius and the gluteus maximus. This is the iliotibial band, and we see portions of the tensor fascia lata, and also in this location, arising from the anterior superior iliac spine, we see the sartorius. So as we extend distally, we see the sartorius, tensor fascia lata, iliotibial band, and we nicely see that anterior facet containing the gluteus minimus insertion, the superior posterior facet containing the gluteus medius insertion, the lateral facet containing the other portion of the gluteus medius tendon insertion, and then between the posterior and lateral facets and the iliotibial band, we see the location of the true greater trochanteric bursa. We also have external rotators of the hip, and those include the piriformis, the quadratus femoris, the obturator internus, the superior and inferior gemelli muscles. The piriformis plays a significant role in that it can be associated with compression of the sciatic nerve and the so-called piriformis syndrome. And as we see in this diagram, they will insert posteriorly on the greater trochanter and also towards the intertrochanteric line. So the most superior muscle will be the piriformis, followed by the superior gemellus, the obturator internus, the inferior gemellus, and finally the quadratus femoris. Also more posteriorly, we'll see the insertion of the gluteus maximus muscle within the posterior aspect of the proximal femur. So on our coronal proton density images, as we extend posteriorly, we see the piriformis, muscle going into the tendon attachment here, posteriorly. We see the superior gemellus here, the obturator internus here, the inferior gemellus here. As we extend more anteriorly still, we see the obturator externus muscle and tendon inserting. Superior and inferior gemelli together with the obturator internus are known as the triceps coxae muscle. Axial images, piriformis inserting into that posterior superior margin of the greater trochanter, obturator internus and externus, and then finally we see the quadratus femoris. The quadratus femoris can be injured in the setting of ischiofemoral impingement syndrome. The quadratus femoris is adjacent to the sciatic nerve, as well as the hamstring tendon origins, including the semimembranosus, the biceps femoris, and the semitendinosus. The quadratus femoris on coronal images is seen here, inferior to the area of the obturator externus. This is the obturator externus. This is the quadratus femoris. On the sagittal images, we'll see the piriformis, the sciatic nerve, the superior gemellus, the obturator internus, the inferior gemellus. This is known as the triceps coxae. And on this image, we see the piriformis, superior and inferior gemella, obturator internus, and then the obturator externus is here. The quadratus femoris is here, and this is the sciatic nerve. Now, in terms of the hip extensors, we have the gluteus maximus. We have our hamstrings, including the long head of the biceps femoris. Remember that the short head is only a knee flexor, and the short head will start at the level of the femoral diaphysis and insert together with the long head of the biceps femoris into the fibular head. We also have the semimembranosus and the semitendinosus. So the gluteus maximus will attach posteriorly and medially to the iliac crest, as well as portions of the sacrum and coccyx, and then insert into the posterior margin of the proximal femur. And here's the close relationship between the piriformis with the sciatic nerve traveling anteriorly, and then the superior gemellus, the obturator internus, and inferior gemellus, and the sciatic nerve traveling from anterior to posterior and from proximal to distal between the piriformis and the superior gemellus. And then more inferiorly, we see the quadratus femoris. We see first the semimembranosus tendon, which attaches more superiorly or proximally and laterally on the ischiotubosity. And then we see the biceps femoris and semitendinosus. Now, the semimembranosus and semitendinosus will travel medially, while the long head of the biceps femoris will travel laterally. If we continue more medially, we see the adductor magnus, and then most medially we will catch the gracilis. On our axial images, as we scroll from proximal to distal, we follow the sciatic nerve. As we extend distally, we have the semimembranosus, biceps femoris, and semitendinosus. On our sagittal images, we'll see the semimembranosus tendon laterally, and then we will catch the biceps femoris and semitendinosus insertion. The hamstring tendon origin at the ischiotuberosity has the semimembranosus as well as the conjoint tendon of the biceps femoris and semitendinosus muscles posterior medially. The semimembranosus muscle is anterior lateral. The sciatic nerve is always lateral. As we extend more distally, we'll see the semimembranosus, and that will travel from lateral to medial together with the semitendinosus, while the biceps femoris will go laterally. At the level of the mid-thigh, we see the origin of the short head of the biceps femoris along the posterior aspect of the femoral diaphysis. This is the long head of the biceps femoris. We have the semimembranosus, which will be more anteriorly and medial, and the semitendinosus, which will be more posterior. So the biceps femoris is a double muscle. It has the long head arising from the medial facet of the ischiotuberosity, and the short head arising from the lateral linea aspera, the lateral supracondylar line, and the intramuscular septum. The long head is innervated by the tibial portion of the sciatic nerve, and the short head by the peroneal division. The hip flexors include the iliopsoas, which is made up of the psoas major, the psoas minor, and the iliacus muscle, the rectus femoris, and the sartorius. So here's an image representing the iliopsoas. We see the psoas major arising from T12 through L4. We see the iliacus, and past the area of the inguinal ligament becomes the iliopsoas. We see portions of the iliopsoas tendon crossing the joint line. This is the iliacus, and here we have the psoas muscles. The iliopsoas will insert into the lesser trochanter. These are coronal proton density images showing the iliopsoas complex. This is the iliacus, this is the psoas. You're past the level of the inguinal ligament and becomes the iliopsoas. You can see both tendon and muscle fibers cross level of the inguinal ligament and then traveling inferiorly to insert both the tendon and the muscle into the lesser trochanter. On our oblique axial images, we see the area of the anterior inferior iliac spine. This is the direct head of the rectus femoris. The reflected head of the rectus femoris will originate along the superior lateral rim of the acetabulum. We also see portions of the iliacus as well as the psoas forming the iliopsoas complex. As we extend distally, we see the direct head and the reflected heads of the rectus femoris. And here is the rectus femoris. Again, sartorius, tensor fascia lata, rectus femoris, iliopsoas. As we follow the iliopsoas distally, we'll see the insertion into the lesser trochanter. On our sagittal images, we'll follow the iliopsoas complex crossing. We can see that there's both a tendon crossing the joint line as well as a muscle. Anteriorly, we can follow the iliopsoas tendon. This is the labrum, the anterior labrum, which we'll be discussing later on. And as we extend a little bit further laterally, we see portions of the transverse acetabular ligament. This is the femoral head. This is the fovea. This is where the Ligamentum Teres femoris will travel. The rectus femoris has both a direct head, which arises from the anterior inferior iliac spine, and an indirect or reflected head, which originates from the supra-acetabular ridge, and distally they form a conjoined tendon. Each tendon nearly retains a separate identity. So on this diagram, we see the direct head of the rectus femoris originating from the anterior inferior iliac spine, and here we have that reflected head. And so on our coronal images, we can follow the rectus femoris as it extends distally, and on our sagittal images, we see both the direct and the reflected heads. Now, injury to the rectus femoris muscle is common in athletes, second only to the hamstring among lower extremity injuries, and as we follow the direct and reflected heads of the rectus femoris, their position will change depending at what position we acquire images through the rectus femoris muscle belly. So proximally, we'll have the direct head being anterior and the indirect being medially. As we extend distally, the indirect or reflected head will assume this comma-shaped structure within the muscle substance, while the direct head will have this flat appearance along the anterior aspect of the muscle belly. So here again, we see that direct head and that linear or that curvilinear structure within the muscle being the indirect head. So the direct head forms primarily the superficial anterior tendon. The indirect or reflected head primarily contributes to the deep central intramuscular tendon. This unusual tendinous and muscle within a muscle architecture results in patterns of muscle tearing that differ from what is typically encountered. So these are axial images showing the direct and reflected heads. As we extend distally, we can start seeing that curvilinear appearance. The direct head will be anterior. The reflected or indirect head will be more curvilinear within the substance. And so again, more distally, we see that direct head anteriorly and the indirect head centrally. Now the iliopsoas tendon complex, the psoas has a tendon attachment onto the lesser trochanter of the femur. The iliacus has a direct muscle attachment onto the lesser trochanter and a tendon located eccentrically within the distal muscle belly. The intramuscular tendon is in the medial aspect of this portion of the iliacus muscle and is separated by fatty fascia from the iliopsoas tendon and attaches to the distal iliopsoas tendon just at the level of the lesser trochanter. This accounts for the MR appearance of two parallel hypointense structures. So here we see the iliacus tendon, which is a direct muscle attachment and short tendon, and we see the psoas tendon being the smaller tendon, fatty fascia between them. Now, you can have an accessory iliacus tendon. So the iliopsoas tendon complex includes the iliopsoas tendon, which attaches to the lesser trochanter, the lateral portion of the iliacus muscle that attaches directly to the anterior portion of the proximal femoral diaphysis, and you may have the accessory iliacus tendon, which is a thin intramuscular tendon within the lateral portion of the iliacus muscle. And this accessory iliacus tendon and muscle are very common and found in up to 66% of patients. Now, when we talk directly about the hip joint, we'll discuss the hip joint capsule and capsular ligaments, the labrum, articular cartilage, and then imaging pitfalls that can mimic injuries. So the Ligamentum Teres femoris has two bands that attach onto either side of the acetabular notch. Between the bony attachment of the ligament blends with the transverse acetabular ligament. So this is the Ligamentum Teres femoris. This is the transverse acetabular ligament. This is the inverted horseshoe appearance of the articular surface of the acetabulum. This is the area of the pulvinar, the cotyloid fossa, or the acetabular fossa. We see portions of the obturator nerve and obturator arteries. So there is the labrum covering the articular surface of the acetabulum. Along the articular surface of the acetabulum, we will see a hyaline cartilage. This is the area of the fat pad or pulvinar. There is the Ligamentum Teres femoris, pubofemoral ligament, and inferiorly we'll see the obturator nerve with the anterior and posterior branches of the obturator artery and veins, and finally the obturator membrane. So the hip joint capsule, the proximal attachments of the capsule along the osseous rim of the acetabulum. Typically the capsule inserts near the base of the labrum, creating perilabral recess, which we see on MR arthrography. Anteriorly and posteriorly the capsule courses further away from the acetabular margin, and the recess is deeper, particularly anteriorly. The capsule attaches distally along the anterior aspect of the femoral neck at the base of the trochanters, the intertrochanteric line. Here's that appearance of the perilabral sulcus formed by the capsule and the labrum. So this is a coronal T1 weighted arthrogram image of the hip, showing that the capsular attachment is several millimeters above the acetabular rim, and that creates a larger superior perilabral sulcus. The Ligamentum Teres femoris, or fovea capitis, arises from the fovea of the femoral head, and inferiorly it will travel to blend with the transverse acetabular ligament. We also see the circular fibers of the Zona Orbicularis in cross-section. The inelastic fibrous joint capsule of the hip is reinforced by capsular ligaments. Anteriorly, we'll see the iliofemoral ligament, also known as the ligament of Bigelow. It is the strongest and thickest of the capsular ligaments. It courses inferiorly from the iliac body and the anterior-inferior iliac spine in two distinct directions with two bands that give it an inverted Y shape. So here is a representation of the iliofemoral ligament and the two bands, the medial band and the lateral band. And we can see that the lateral band will insert anteriorly and laterally on the intertrochanteric line, while the medial band will insert more medially towards the lesser trochanter. So here is that inverted Y appearance of the ligament of Bigelow, also known as the iliofemoral ligament. Now more medially, we'll see a thinner ligament known as the pubofemoral ligament. So on axial images, this is the iliofemoral ligament of Bigelow. So here's the appearance on axial images of the iliofemoral ligament, the medial band, and here's the appearance of the medial band on a sagittal MR image. This is a coronal proton density image showing the lateral band of the iliofemoral ligament. Now the pubofemoral ligament extends from the anterior border of the superior pubic ramus to the intertrochanteric line. It acts as a check against pathologic extension of the hip. So here is the pubofemoral ligament. On sagittal images, we'll catch it inferior to the transverse acetabular ligament here. On coronal images, we will see a thin wisp of tissue traveling between the pubic and femoral bones. And on axial images, we'll see it here. Posteriorly, we see the ischio-femoral ligament, which is a broad and less dense condensation extending in the oblique and horizontal fashion from the ischial border of the acetabulum to the superior base of the femoral neck in the region of the trochanteric fossa. Some of the deeper fibers pass in a circular fashion, which constrict the capsule to form the collar around the femoral neck, which we see as the Zona Orbicularis on our MR arthrograms. So this is the ischio-femoral ligament, and we see both horizontal fibers and we see those circular spiral fibers that will form the Zona Orbicularis. And so here is that ischio-femoral ligament. So posteriorly on axial images, we see the ischio-femoral ligament here. See that ischio-femoral ligament posteriorly. On sagittal images, we'll catch the ischio-femoral ligament here, deep to the piriformis, superior and inferior gemella, and obturator internus. So ischio-femoral ligament. The Zona Orbicularis is formed by the spiral fibers of the ischio-femoral ligament. It is present at the base of the femoral neck, circumferentially surrounding the posterior capsule, but not directly attaching to the femur. Arthroscopically, the Zona Orbicularis may be mistaken for the acetabular labrum. So here's a representation of the Zona Orbicularis. And so as we scroll on our coronal images, we'll see that pinching posteriorly of the femoral capsule made by the Zona Orbicularis there. These are T1 fat suppressed images, and we see the fibers of the Zona Orbicularis. Now the acetabular labrum is composed of fibrocartilage and therefore should be low signal intensity on all MR sequences. It arises directly from the rim of the acetabulum. It is important but not critical for providing stability of the hip joint, in contradistinction to the glenoid labrum of the shoulder. Alterations in the labrum predispose the hips to osteoarthrosis. And so here is that acetabular labrum formed by fibrocartilage, and here it is low signal triangular shaped superior lateral acetabulum on our coronal protendensity images. So the acetabular labrum prevents cartilage loss by deepening the acetabular socket and increasing the coverage of the femoral head, thereby reducing mechanical stress on the articular cartilage. It helps to maintain a vacuum seal of the hip joint. It provides a pressurized fluid level, and it resists the flow of interstitial fluid out of the articular cartilage. And so on our coronal images, we see posterior superior labrum, superior lateral labrum, anterior superior labrum, anterior labrum, and anterior inferior labrum. On our axial oblique images, we see the anterior inferior labrum, the anterior labrum, the anterior superior labrum, superior lateral labrum, posterior superior labrum, posterior labrum, and posterior inferior labrum. Sagittal images, we see the transverse acetabular ligament, we see the pubofemoral ligament, we're seeing portions of the iliopsoas complex, and as we extend from medial to lateral, we start seeing the acetabular labrum anteriorly, and this represents combined iliopsoas and also the iliofemoral ligament. Here is that anterior labrum, anterior labrum, anterior labrum, anterior superior labrum, extending into superior lateral, posterior superior, posterior, and posterior inferior labrum. This gray structure around the femoral head and around the acetabulum is the articular cartilage, the hyaline cartilage. There are several imaging pitfalls, including normal sulci, pitfalls in interpreting the appearance of the normal labrum in close proximity to the capsular structures. There have been several that have been identified, including the posterior inferior sulcus, the anterior superior cleft, the transverse acetabular ligament labral junction sulcus, and the perilabral sulcus. So here's an example of a posterior inferior sublabral sulcus. It can be seen arthroscopically, may be mistaken for posterior labral tear on axial images, usually seen on one or two axial oblique images superior to the transition between the transverse ligament and the posterior inferior labrum. And this is what it appears like arthroscopically. The anterior superior cleft, which is controversial, on the lateral coronal images and sagittal images is present, undercutting the labrum on a single image. A more commonly seen in labral hypertrophy associated with mild developmental hip dysplasia or acetabular dysplasia. Here is the transverse acetabular ligament labral junction sulcus, which is a normal recess between the transverse acetabular ligament and the labrum on either anteriorly or posteriorly. So here is that transverse acetabular ligament, and here is that anterior transverse ligament labral junction sulcus, and here is that posterior transverse ligament labral junction sulcus. The perilabral sulcus is usually seen on MR arthrogram as contrast fills the perilabral recess between the capsule and the labrum. So here we see the area of the transverse acetabular ligament with Ligamentum Teres femoris, and here are the areas of the perilabral recess adjacent to the normal superior labrum. So here is that area of the perilabral recess. We also may see synovial herniation cysts or pits along the anterior aspect of the femoral neck-head junction, seen in up to 33% of patients with femoroacetabular impingement and between 4 and 12% of the general population. Authors have proposed a direct relationship between the herniation pits and femoroacetabular impingement. The mechanism is thought to be due to extreme hip flexion with internal rotation. An alternative proposal is pressure of the iliopsoas muscle on the joint capsule with the hip in extension. Ossific fragments along the superior lateral rim of the acetabulum may represent os acetabula. So the acetabulum is formed by the fusion of multiple primary and accessory ossification centers that can appear as early as the age of 6. By the ages of 18 to 20 years, these ossification centers should have united. In approximately 2 to 3% of asymptomatic patients, an accessory ossification center may persist as an ossicle known as the os acetabula. Os acetabula are unfused to the acetabulum and are usually surrounded by intact hyaline cartilage. Acetabular rim fragments from femoroacetabular impingement syndrome can be difficult to differentiate from os acetabula. So here are examples on a coronal CT and coronal T1 weighted MR of os acetabula. On MR arthrograms or MR imaging in the presence of a large effusion, we may see plica, which are synovial folds commonly located at the interface of articular surfaces. They are embryonic remnants. They're generally asymptomatic. However, they can become symptomatic by either mechanical impingement or mass effect on other structures. On MR arthrography, the labrum, femoral neck, and ligamentum plicae are on MR arthrography. The labral, femoral neck, and ligamental plicae are found in 76, 97, and 78% respectively of asymptomatic hips. So here are examples of labral, femoral, neck, and ligamental plicae. The pectineofoveal fold, also known as the middle retinaculum of Whitebreck. The location is most important criteria to differentiate pectineofoveal fold from plicae. It extends from the lesser trochanter to the fovea capitis. It contains the posterior inferior retinacular arteries and the branches of the medial femoral circumflex artery. Unlike plicae, the pectineofoveal fold is unlikely to become symptomatic. So here's an example of a pectineofoveal fold on coronal and axial images. And here it is arthroscopically. Now, the femoral head articular cartilage is thickest posteriorly and superiorly, measuring up to 3 millimeters, and its thinnest along its peripheral and inferior margins, measuring up to 0.5 millimeters. Centrally, we have the area of the fovea capitis, where the ligamentum teres femoris will attach. The acetabulum has an inverted horseshoe or lunate-shaped appearance, which provides bony coverage of up to 40% of the femoral head. The acetabular fossa is in the inferior medial portion of the acetabulum. So here is the acetabular fossa. This is the acetabular notch, and that demarcation along the inner margin of the articular surface is known as the articular ridge. So here is a more detailed representation of the acetabulum. The lateral acetabulum is directly superiorly and the medial acetabulum is directly inferiorly. The stellate lesion or stellate crease is a bare area deficient of hyaline cartilage above the anterior superior margin of the acetabular fossa within the articular area of the acetabulum. This area may appear as an indentation arthroscopically and on MR imaging in this location here. So this is what it looks like arthroscopically. And here is an MR representation of the supraacetabular fossa. So these are anatomic variants whereby a focal defect is evident within the subchondral bone of the acetabular roof. In 10% of hips is typically located at the 12 o'clock position on both the coronal and sagittal planes as depicted here. So the stellate crease is that bare area within the acetabular articular surface deficit of hyaline cartilage and is located above the anterior superior margin of the acetabulum and medial to the supraacetabular fossa. Thank you for your attention.